Welcome to this Beyond Zero e-learning module. This is one of the Wits RHI catch-up sessions and is focusing on the DRTB side effects. This particular module is the first of 3 and will be focusing on the neurological, metabolic, abdominal, and musculo-skeletal side effects. The side effects of the DRTB treatment are numerous and some of them are quite serious. And doctors often feel overwhelmed in how to manage the adverse events of patients on DRTB treatment. The way we're going to approach it is by looking specifically at systems. So when the patient presents to you, they're going to present with a group of symptoms. And it's not even always that easy to establish which particular drug is causing the problem. So it's more important to be able to identify symptoms early and know how you approach those particular systems. In this first presentation, we're going to be looking at the nerve sense system, quite dramatic issues such as hearing loss, vision, seizures in mental health, less common but can be an issue. Peripheral neuropathy, quite a common issue on DRTB treatment. We'll also be looking at our endocrine and abdominal side effects, such as hypothyroidism and patients presenting with nausea and vomiting, very common. And then in the next presentation, we'll be looking at musculo-skeletal side effects as well as skin reactions. And we'll also spend a little bit of time on how to properly assess both renal impairment as well as the risk of arrhythmias in patients on DRTB treatment. So first, let us look at side effects to do with our nervous and sensory system. Hearing loss is a disaster for a patient on DRTB treatment, and it's probably also the one that gets the most press. We all know that the number one culprit for this are our injectables, and most of our adults will be on kanamycin, our children will be on amikacin. The challenge is that you lose the high frequencies first, and therefore it might not be obvious to the patient until they're starting to reduce hearing loss and normal communication that there's a problem. So quite often, if we're waiting for the patients to report problems, we're going to see it late. Also note that injectables is an issue in pregnancy because it can affect the development of the baby's ear. So therefore, the guideline and the protocol very strongly advises to do baseline and monthly audiometry tests until 3 months after the completion of the injectables. And you can be liable if a patient goes deaf on DRTB treatment and you do not pick up the fact that there is a problem early on. And this can be a challenge because we don't always have access to reliable audiometry. The management, if you start picking up problems early, is one can initially try to reduce the dose and the frequency. But as we now have bedaquiline available, usually in these patients, we will switch them to a bedaquiline-based regimen. For patients who have very mildest vestibular symptoms, we can use metoclopramide or chlorpheniramine to help for those. Optic neuritis is a rare complication, but a serious one, and it's therefore important that we are vigilant. Our number one culprit is ethambutol, which we also use in drug-sensitive TB, but it's actually very much dosage-dependent complications. So we see it in patients who are on more than 15 milligrams per kilogram per day, and usually we only start seeing it after patients have been on treatment for somewhere between 2 and 12 months. Similar with the hearing loss, the challenge is that it starts off very slowly, painlessly, and often as a central scotoma. And the patient might not be aware of it until the damage is quite severe. It's therefore recommended to do a baseline visual acuity test as well as a monthly one. And then Retrobulbar neuritis, which is actually a little bit more common but not as severe, as doesn't cause visual disturbance as severe as the optic neuritis. For that, it is also good to be able to do a red and green color vision test. It's fully reversible if we do pick it up early, and it's therefore important to be vigilant. If there is any visual acuity or visual disturbance issues, it's important to stop ethambutol immediately. For retrobulbar neuritis, patients might have blurred vision, but more often might present with red-green color blindness, and you're not going to pick this up unless you do something like the Ishihara Test, where you give them these patterns and ask them if they can see the numbers, and because these can easily be downloaded and printed off the internet. Another neurological complication is that of seizures or tremors. This is also not so common, but can be very dramatic and concerning for the patient. And our worry here is usually the high dose INH. In normal dose, it's INH, seizures is hardly an issue. The fluoroquinolones could also contribute, and the concern is maybe the two drugs together in a patient who might already have a tendency towards seizures could precipitate attacks. In our patients on ex-DRTB patients, both capreomycin and taurursodone can also be an issue. So what do? We immediately increase the pyridoxine to 200 milligrams per day, but very important, we have to make sure that it is actually to do with the medication. For a patient with MDR-TB, especially if they've got HIV co-infection, there might be many other contributions that might be causing seizures, such as tuberculoma, for example, or even other infections such as cryptococcal meningitis. If the patient does need anticonvulsants, it's important to use sodium valproate if they're on ARVs, or if they're HIV negative, you could use phenytoin until the seizures have settled down. And if you do think it's the drugs, it'll be important to either discontinue or lower the dose. And this is usually through excluding all other possible causes that we'll say, well, maybe the drugs is the problem, and you would have to look at adjusting the regimen. More common than seizures and some of your other nerve symptoms is either a psychotic attack or an increase or precipitation of symptoms of anxiety and depression. The drug that we always worried about the most is taurursodone, which is one of our ex-DRTB drugs. But in our current 9-month MDR-TB regimen, we have got clofazimine, which, although not as much as taurursodone, but can also increase mental health symptoms. And to a lesser extent, also ethionamide has been implicated. Very important to do a full mental health assessment and to keep into consideration the larger picture. Patients with DRTB has got a severe stigmatized disease. It's treatment they have to take for a very long period of time. And there might be a lot of social factors that can also be playing a part. If we think the drug is indicated and the patient especially is very unwell, it will be important to reduce the dose or maybe even having to change that drug. Always check for suicide risk, especially for patients who have been diagnosed with an illness that is potentially fatal. And those patients might decide that it's just not worthwhile to keep trying. Apparently one can try and increase the dose of B6. It certainly can't do any harm, to see if that might help. And one might have to use antipsychotics if it's absolutely essential to keep that drug going. Then it's important to add something in. And one can use either allopurinol and risperidone is safe, and one can use lorazepam for severe anxiety. Peripheral neuropathy is also one of the more common complications, and it's important to manage this well because it can certainly, from the patient's perspective, be a reason for discontinuing treatment. Our number one suspect here is that high-dose INH, and clofazimine is also implicated. And then for our XDR patients, very much so taurursodone. And of course, the problem is when we're starting to combine different drugs that all can lead to peripheral neuropathy, and they can potentiate each other's effects. Injectables have also been implicated, as is ethionamide and even the fluoroquinolones to a much lesser extent. And the issue, I think, is more to do with the fact that we have several drugs that can contribute to peripheral neuropathy. And it's therefore sometimes difficult to know actually is there one drug that is the culprit. So therefore, all patients on DRTB treatment must be on pyridoxine, 150 milligrams a day. And if you do start developing any symptoms, one must not be shy to increase that dosage. We can use amitriptyline or gabapentin to help for symptoms. Important to remember that we can't use amitriptyline with bedaquiline, as both of them increase the QT interval. And if you are, probably in this case, we might look at reducing, for example, the high-dose INH or replacing it with something else. What's interesting is that there is actually advice for particular exercises the patients can do to help for the peripheral neuropathy. And I've got a few of them on the next slide here. There's 3 little exercises that you can quickly show the patient how to do. The first one there is called the clock. It's a foot and balancing exercise where you are standing and you're imagining yourself in the middle of a large clock. You keep the one foot in place, for example, the left foot. You extend your right leg and touch as many of the numbers as possible, going round clockwise around the clock, and then you do that with the other foot as well. The second exercise there, very easy, is a sock lift. You get them to pick up a sock from the floor 6 times with each foot. And the third one there is calf extension, when you're sitting on the floor with the one foot extended out in front of you, and you take a rolled up towel and you actually pull the towel, you put the towel over the end of your foot, and you stretch it towards your body. So this is obviously not your, you obviously want to add this to some of the other medication that you might be using, but patients could find this useful to help for symptoms. So let's look at some of our metabolic and abdominal side effects, common with all kinds of medication that one is taking. The one that is sneaky and that you must watch out for is the patient who's tired, constipated, gaining a bit of weight. All they might tell you is that they're not feeling very well. We're obviously quite happy if patients are gaining weight on their DRTB treatment, and we quite often expect them to be tired because they are unwell. What's important is not to miss hypothyroidism. Also not that common, but something that's very easy to treat and very easy to manage. So our number one culprit here is ethionamide and PAS, which we don't really use much anymore. You might see it in some of the XDR regimens. But ethionamide is one of the key drugs that we have in our first-line regimen. And it's therefore important to warn patients as well, to also come and tell you when they start experiencing the symptoms. Do check for anemia as well. That can also lead to tiredness, and both the illness and some of the drugs can make one anemic. But it's therefore recommended that we do a TSH at baseline, at 3 monthly, and whenever the patients are symptomatic. And this is only for patients who are on ethionamide. If you do find that you have a very high TSH, then we're going to initiate levothyroxine, and this can actually be very helpful for symptoms. And it's quite often reversible. So once the patient stops the DRTB treatment, the thyroid hormones will return to normal level. Quite a common and often also quite problematic side effect is that of either nausea and vomiting or intermittent diarrhea or abdominal pain. And this can be a problem not only because the patients might not want to take their treatment, but it can also lead to poor absorption of the treatment. Our number one culprit that you're going to think of first here is ethionamide, same one that causes hypothyroidism. And to a lesser extent, ethambutol, PZA, and clofazimine. But as you know, with our drug-sensitive TB, we don't see that many patients with issues on the ethambutol and PZA. Very important to manage this well, because this can really lead to treatment failure if we're not careful. So we can look at splitting the dose of the ethionamide to 2 or 3 dosages over the day. That quite often helps, or trying to take it in the evening so that by the next day the nausea has settled down. One can also consider a lower dose. In this scenario, taking the medication with food might help. And if they're nauseous, you can recommend they take small and bland frequent meals. It's very important to make sure you keep an eye on the weight and monitor the electrolytes to make sure that the vomiting or diarrhea is not starting to affect them. And it's very helpful to take their symptoms seriously, and with nausea to give them some antiemetics 30 minutes before meals, before they're actually going to take their treatment. And metoclopramide is usually recommended here. Loperamide has a place for the diarrhea, but only once you have excluded any of the infective causes. So also important to send some stool cultures. It might, for example, be an iris of something else. Much less so, but also worth remembering, is gastritis, so heartburn, which can not only be caused by the DRTB treatment, but by a whole range of other factors in people's lives. And our number one culprit here is clofazimine and ethionamide, who are both part of our first-line regimen, and our XDR-TB, our PAS specifically. And we manage it pretty much like we normally manage gastritis. So we would tell them to avoid caffeine, cigarettes, and very spicy food. We need to keep an eye on the hemoglobin, just in case of a bleed. And one can use PPIs, one can use your normal H2 blockers. But if you are going to use any of your antacid treatments, it's important to give it 2 hours before or 3 hours after the TB medication, as it could affect the absorption of some of our treatment. So generally we try and take, for example, our TB medication, if we're taking them in the morning, you will take your PPIs, for example, at night. We also have to be very much aware of our drug-induced liver injuries, as we are with our drug-sensitive patients. And our number one culprit here, as it is with drug-sensitive TB, is our PZA. The high-dose INH might also be contributing, as well as bedaquiline. And even the fluoroquinolones, the ethionamide, and ethambutol can all, to a much lesser extent, also have an effect on the liver. The challenge is therefore also that we're not always sure which drug might be causing the problem. We will use the same definition for a drug-induced liver injury as we are using for our patients with drug-sensitive TB. So any patient where the ALT is more than 125 and the patient is symptomatic will be qualified as a DILI until otherwise proven, or if the ALT is over 200, even if the patient is asymptomatic, or if the total bilirubin is over 40. It's probably going to be very uncommon to see an isolated hyperbilirubinemia, as those are usually caused by our rifampicin, which these patients are not on. Your PZA will classically affect those hepatocellular enzymes. And this is very important that we might need to stop the PZA, and you would discuss urgently with an expert. In our patients with drug-sensitive TB, because INH, PZA, and rifampicin can all three be implicated, we normally would stop the whole course and put patients on what we call a liver-safe regimen. It's going to be very different for our patients on DRTB treatment, and these patients need to be falling under expert care. Let us now look at some of the musculo-skeletal side effects or issues we can see on DRTB treatment. Electrolyte disturbances can actually also be grouped under kidneys, but quite often the way they present is with cramping in the legs or muscle weakness or feeling fatigue in the muscles. And you would need to have a high suspicion and just check the electrolytes, either to do with a low potassium or low calcium or low magnesium. And of course, our number one culprit is kanamycin. So the same effect it has on your renal function, on your creatinine, can also be affecting your electrolytes. And it's easy to correct with supplementation, and rarely would you need to discontinue the drug because of electrolyte disturbances. Just make sure you pick it up early. So we do see patients sometimes presenting with arthralgia or actual arthritis or severe muscle ache that is not due to electrolyte disturbances. Our number one culprit here is PZA, and to a lesser extent your fluoroquinolones. Bedaquiline has also been implicated, but this is a relatively uncommon side effect, as you would know from patients with DSTB. We don't often see patients presenting in this way. Just make sure your patient is on the correct dosages, as this is very dosage dependent. All of the side effects can increase, for example, if a patient has renal dysfunction and we haven't adjusted the dosages of their renally excreted medication. We can give our normal symptomatic advice: hot showers, ice, and using our anti-inflammatories are safe to use with our DRTB treatment, ibuprofen, aspirin, which you can combine with paracetamol or codeine. At one point we used to do uric acids. It's not really going to change your management. Even if it's a little bit up, you're still going to use ibuprofen, or your anti-inflammatories is your main intervention, and it's therefore not recommended as a routine test. Thank you. In the next module, we'll be focusing on the dermatological, renal and cardiovascular side effects, and a little bit on both creatinine interpretation as well as ECG interpretation. The third little module will be focusing specifically on how we monitor patients on DRTB treatment.